Hi, everyone. Thanks for joining today. I am your moderator, Julia Zuckerman, here from Siegel's Compliance Practice. And we are going to talk about, on this webinar, the vast range of reforms that are affecting pharmacy benefit delivery. As pharmacy benefit managers and plan sponsors navigate this new landscape, it is driving change and certainly elevating compliance risks that we will discuss. Okay, so I think we can continue with the next slide. Today, I'm joined by Elena Lynett, who is a Senior Vice President and the National Health Compliance Leader here at Siegel, and also by Eileen Pinkay, who is a Senior Vice President and the National Pharmacy Practice Leader. And these two esteemed individuals will lead us through a discussion overviewing pharmacy trends and market updates, reviewing new legal requirements, both on the legislative side and on the regulatory side, as well as executive initiatives that impact pharmacy benefits. Finally, Eileen and Elena will discuss pharmacy benefit strategies, fiduciary considerations, and fundamental next steps for plan sponsors. I will turn it now to Eileen to kick us off with a discussion of pharmacy trends and market updates.
Thank you, Julia. You can move to the next slide. So I want to start by grounding us in the PBM landscape, because this really helps explain why pharmacy benefits can feel so complicated from an employer standpoint. At the top left are the so-called big three PBMs. So you have CVS Caremark, Express Scripts, and Optum. Together, they manage the majority of prescription volume in the US and are integrated with very large healthcare organizations like Aetna, Cigna, UHC. The scale can be really powerful, but it also introduces complexity and potential conflicts. Then there's the middle tier of PBMs on the right that you see there. Organizations like MedImpact, Navitus, Prime, and others. These tend to position themselves as more flexible or transparent, maybe even have tighter formularies and stricter utilization management. And then on the other end of the spectrum are the smaller or more niche PBMs like Capital RX, Smith RX, EmperX, Rightway, and others. So these PBMs are usually more customized, maybe a more hands-on approach for the employer and more flexible formularies. And the big takeaway here is that the PBMs are not all built the same. Knowing what type of PBM you're working with is really important in understanding how they're managing pharmacy costs, risk, and transparency. Next slide, please. So once you understand how pharmacy benefits are managed today, the next logical question is, what's coming next? What does this mean for future cost and risk? When you look ahead, there are several forces that are going to keep pressure on pharmacy spending. First, the drug pipeline, as you can see there on the right, remains very active. Approval volumes continue to be strong, especially in the rare disease and oncology space. So even though these populations may be much smaller, the therapies are really, really expensive and typically add to the total spend rather than replacing something else. Second, pricing volatility isn't going away. We're still seeing regular brand price increases alongside some price cuts on some high-profile drugs. And then the third is that the FDA pathways are still accelerating launches. So manufacturers are taking advantage of these expedited approvals to get drugs to market faster. And what does that really mean? It means that employers feel the cost impact sooner. Chronic disease demand is another major driver. So more than half of the US adults have at least one chronic condition. And categories like GLP-1s and biosimilars, they continue to grow rapidly. So these are long-term therapies, not short-term fixes. And finally, rising fiscal pressure, especially at the federal and state level. It's really driving a focus on drug pricing and PBM practices. Next slide. So all of this information so far feeds directly into what we're seeing around projected cost trends. For outpatient prescription drugs, trend remains elevated, so about 11.4% in 2025, easing slightly to 11% in 2026. And when you turn to specialty drugs and biologics, the impact becomes even clearer. So specialty trend is projected at 13.3% in 2025, dropping to 11.9% in 2026. So even with that step down, specialty really remains the dominant driver of pharmacy spend. So while we may see some year-over-year moderation, the underlying things we discussed earlier, like innovation, utilization, specialty growth, they really keep pharmacy trends firmly in the double-digit territory. Next slide. So we've talked about where things are headed, but it's also helpful to step back and look at how drug trend has been behaving over time. So what this chart shows, it shows rolling 12-month cost trends on a PMPM basis. And what's important here is really the direction that you're looking at. So in late 2022, trend was hovering a little above 10%. And by the end of 2023, it was still in that same range, a little bit higher. But as we move through 2024, you can see the cost steadily climbing, so approaching 14%. So even with some month-to-month variation, the overall trajectory is really clearly upward. And the shaded band that you see there shows some variation across employers. But the midpoint, that's the typical experience, that one keeps rising. And the bottom line, in this slide is that, prescription drug cost growth has really shifted into high gear. Next slide. So where is that growth actually coming from? Coverage decisions matter a lot here. So when a plan covers obesity drugs, obesity becomes the largest driver of trend. And this is largely due to the GLP-1 drugs. So for plans that don't cover obesity management, obesity category drops out, but overall trend really doesn't disappear. So instead, the cost pressure shifts into those other categories. We continue to see strong contributions from areas like psoriasis, oncology, diabetes, and other inflammatory conditions. And these are largely specialty and biologic drugs that drive steady ongoing costs. So really understanding what's driving your spend is what allows employers to be intentional about coverage, guardrails, and long-term risk. Next slide. So before we move on, it's really worth taking a step back and putting some of this in perspective. A big part of pharmacy cost growth reflects a shift in how care is delivered. So treatments that used to happen in the hospitals are now happening through medications taken at home. Weight loss is a great example. What once was potential bariatric surgery is now often managed with injectable therapies. And as a result, pharmacy spending takes up a larger share of the health budget, which makes sense, right? While hospital spending may make up less. And the news is not all negative around pharmacy spend and trend. If you look to the right of the slide, drug innovation has dramatically improved outcomes. So conditions like cystic fibrosis, which once meant frequent hospitalizations and shorter life expectancy, are now often managed long-term with medication. We're also seeing gene therapy, right? And then there's this CRISPR. They're also changing medicine by fixing genes and saving lives. So while pharmacy costs are higher, those dollars are often helping people live longer and avoid intensive care. The challenge here is really balancing that progress with long-term affordability. And then now I'll turn it to Elena.
Eileen, can I ask a question before Elena dives into the new legislative requirements? Could you share your insights on how the evolving drug pipeline is reshaping future spend and what that means for employer benefit strategy?
Sure. Thanks, Julie, for that question. So when you look at what's coming down the pipeline, there are a few areas that really stand out as potential game changers. At the top of that list are metabolic therapies, especially the GLP-1s and the next generation of obesity drugs. What's getting attention now isn't just weight loss and diabetes. It's how quickly these drugs are expanding into other very common conditions like heart disease risk. There's also sleep apnea, kidney disease, fatty liver disease, which is called MASH. So these affect really large population, and most people stay in these drugs long term. What does that mean? It means that costs can add up fast, and they don't really go away. I do want to mention retatrutide. So this is one of the new GLP-1s in the pipeline. It targets 3 receptors, so not just 1 or 2. It targets GLPs, GIPs, and glucagon. So that's 3 different types of hormones that it's working on. And the interesting thing, and the reason I wanted to bring this drug up, is that this drug has demonstrated about 22 to 28% in weight loss. So that one is an exciting one. Yeah, and then the other one I do want to mention is oncology. That's another one that you want to watch closely. More cancer treatments are moving to oral drugs and maintenance therapies. So cancer is increasingly treated as an ongoing condition instead of something that was handled in short-term bursts. So the shift of cancer costs from a one-time event to a recurring pharmacy spend, we're definitely, seeing that grow. And then maybe just one last thing, like psoriasis, inflammatory. So the autoimmune conditions, they continue to grow. That's going to drive up lifetime drug spend for each person who's on that therapy. Okay. Now we'll turn it to Elaine to talk about some new legislative requirements.
Thanks, Eileen. When Eileen and I worked on trying to assemble this deck and presentation, we were kind of overwhelmed with all the information that's that we could be talking about. So we were trying to strike that balance today of how much of the audience was coming with a deep background versus who was new to it, and kind of making sure that we got the word out on the top line things that we're seeing in terms of the industry trends and the new legal requirements that we see moving forward. But we'll be pulling you at the end to see what other things you need to hear, more about, and at what levels, to try to keep this dialogue going, because it's a lot to unpack. So with that, we're going to talk first about the Consolidated Appropriations Act of 2026. So this passed just a few days after the Department of Labor had also issued regulatory guidance related to pharmacy benefit fee disclosures and manager fee disclosures. And so we really had this unique timing that right after sort of a new novel regulation, we had legislative activity. And we can go ahead to the next slide. So the legislative activity amends ERISA, the Public Health Service Act, and the code, and it does apply for disclosures related to larger plans, pharmacy benefit managers providing services to over 100 employees, right? And the legislative requirements become effective for plan years beginning on or after August of 2028. So for most calendar year plans, that's going to be 2029 and have civil monetary penalties. And we can go ahead to the next slide. You'll see as I go through this, I'm going to talk about the DOL Pharmacy Benefit Manager rule next, but really bridging and setting up this concept that a lot of these requirements are similar, related, overlapping, yet sometimes distinct. So that is sort of the current landscape that plans are navigating. The 2026 CAA does require semi-annual reports that PBMs provide to those large self-insured plans. Then it also requires a summary document, something that's easy for participants and beneficiaries to digest if they ask for it to be disclosed. And that has to be provided annually for both self-funded and insured plans. There's also a new disclosure requirement. So again, where we often see that plans have to provide a notice to individuals about the rights that they have. So that is contemplated in that. And we can go ahead to the next slide. So thinking about the types of disclosures that are in the CAA, this is a nice overview summary slide, and you see it includes a list of each drug for which a claim was filed during the reporting period, high cost drugs with gross spending exceeding $10,000 during the reporting period, a list of each therapeutic class of drugs for which a claim was filed during that period, and information regarding affiliated pharmacies or pharmacies under common ownership of the PBM. And we can go to the next slide. Now we start to look at that was like that nice 4-prong high level slide, right? But inside the legislation under each of those, there is really a long list of things that the PBMs need to be providing to the plans. So this is really compensation fee disclosure, but at a very granular level. I'm not going to read through each of the elements in all of these pages, but I think one of the things to really think about as you have that there and digest the different items is that some of these items might be the same as or might be different, again, overlapping some of the requirements we're going to see in that regulatory rule we saw as well. But again, really unpacking this idea of what compensation is being paid by the plan to the PBM, what types of things like rebates are coming forward, all that kind of information, kind of getting that out in a way that a plan could really take a deep dive look at what is really under the hood of the cost of things and what incentives they might not have known about or couldn't see as transparently before. And we can go ahead to the next slide. So again, with a list of each therapeutic class of drugs, again, very detailed reporting requirements. So whether it be information about the net spending on each class after rebates and other remuneration, average net spends in certain periods. So again, I won't go through all the granulars, but you see how detailed this reporting is. And we'll see this again as we go briefly through the next 2 slides. So we can go to the next slide, which is giving us this detail list with respect to drugs that exceed the gross spend over 10,000. So, I think you can start to begin to understand the volume of information that would be contained in these disclosures. Go ahead to the next slide. And then thinking about if a PBM works with affiliated pharmacies, for affiliated pharmacies or pharmacies under common ownership of that PBM, really a breakdown of the disclosures that have to be provided related to that. And this is really, we see the rule kind of moving into breaking things up in the organization. I think folks are really used to thinking about pharmacy. So retail, mail order, and specialty, and really trying to get under the hood and allow plans to take a look at what incentives might be happening when a PBM is having individuals kind of access those drugs through those affiliated pharmacies. And again, very detailed, granular, specific disclosures there listed on the slide for your reference, but that's kind of the momentum of this legislation, right? And we can go ahead to the next slide. So this was another new big requirement under the CAA of 2026, and this is a full pass-through of rebates. So this only applies to ERISA plans, and this is, again, requiring, with respect to PBMs, that they remit 100% of the rebate fees or other discounts or other payments, that all of that goes straight through to that group health plan. And these have to be paid on a timely basis. So it's quarterly within 90 days after the end of each quarter. And plans have to be able to audit that this rebate is pass through is happening. And we can go ahead to the next slide. So there is a nice safety net in this legislation, and this is for, it's termed the innocent plan fiduciary, but this is really getting at this idea that there might be instances where a plan fiduciary really didn't know that the fees weren't being remitted, and then they later in their audit efforts do discover that, and they basically work to get that resolved. And in those circumstances, that does provide liability relief, because you remember I mentioned at the beginning there is liability under this rule for non-compliance, includes civil penalties, and it does provide relief for them there. This would become effective for contracts or renewals entered into for plan years beginning on or after August of 28 as well, so calendar year 2029 plans. So this is a safety net mechanism within that legislation. We can go ahead to the next slide.
Oh, Elaine, actually, could we pause here?
Yeah.
This rebate pass-through is generating a lot of questions. Eileen, from a practical standpoint, could you please share some insights on how PBMs have been and will be reacting to this, and also what longer-term impacts the rebate pass-through may have for plans?
Yeah, so for rebate pass-through, it's definitely getting a lot of attention, and I get why. It sounds straightforward, but it actually changes a lot behind the scenes. So from a practical standpoint, if PBMs are no longer keeping a lot of those rebates, they're going to look for other ways to make up that revenue. So instead of rebates, you may start seeing higher administrative fees, new service charges, or different pricing structures. So the money really doesn't disappear, right? It tends to move. We're also likely to see PBMs rethink how they design formularies. So if rebates matter less, there could be more focus on the list price or the overall net cost. But that transition isn't always clean. It can really create some bumps along the way. For plan sponsors, the big thing to keep in mind is that rebate pass-through doesn't automatically mean lower costs. It just means costs may show up in different places. So it becomes really important to look at the full picture. So not just the rebates, right? You have to look at the total fees, pricing definitions, and how the PBM is getting paid overall. Thank you.
Back to you, Elena. Fee disclosure.
Thank you. Right. So now we get into the other section of the CAA of 2026 that really, again, very much parallels the concept we see in the DOL rule, because now we have that same structure of amending ERISA section 408B2. So basically under ERISA, there is a prohibition for group health plans entering into arrangements with parties of interest where they're prohibited transactions under ERISA. And then there is an exception to those prohibited transactions if certain things are met, if it's a service that's really necessary for the plan, if the arrangement that's been entered into is reasonable, if the compensation for that relationship is reasonable. So that's kind of that basic ERISA structure. And now we see the legislation amending that to really focus on group health plan transactions with their PBMs in that context, and looking at certain things as would otherwise be a prohibited transaction unless certain requirements have been met that really support that reasonableness factor. Okay. And so with that, we can go ahead to the next slide. So we see that framework. We also saw some other amendments, which we'll spend a little bit less time on because I think for this group, they're not as much of a focus. But there were other reforms within the CAA, so including moving PBM reforms to Medicare and Medicaid, and also extending existing public health programs. So funding for programs such as pediatric cancer research and HIV prevention. So we have, that area of reforms happening within the legislation as well. And we can go ahead to the next slide. We also have some other things happening within the CAA, extending coverage for telehealth services for Medicare. So I think that's something that there's been significant support for, and we see that moving forward. Looking at neutral reforms that require billing with separate national provider identifier services for services in separate facilities. So again, these are some, other more granular reforms that were in the CAA that we're just mentioning for you. We can go ahead to the next slide. So here, we're just kind of pinning a theme that the amendments in the legislation under the CAA really do start to trigger questions about exercising due diligence in PBM contracting, thinking about how plans would monitor this PBM reporting, the obligations, thinking about how review of these disclosures will work, and looking ahead at those contract negotiations in the future. And we're going to really see this consideration deepen as we take a look at some of the other legal requirements that we see changing at the same time.
So, Elena, just a few days before the PBM reforms within the 2026 CAA were passed, the DOL issued a proposed rule that seems very similar. It also advances PBM fee transparency. The regulatory guidance from the DOL was issued in response to President Trump's executive order 14273, the lowering drug prices by once again putting Americans first. That was the executive order that instructed the DOL to propose regulations that would be designed to improve transparency into both direct and indirect compensation that PBMs received. Could you tell us a little bit about the new regulatory framework and the interaction between the DOL's proposed rule and the CAA? Frankly, this reminds me of the transparency rules finalized in 2020, only for the No Surprises Act to pass in Congress a couple months later.
Right. It's interesting how we have these timing events sometimes. And I think we can go ahead to the next slide. That's a great segue into the next section. And we can go ahead to jump into that content to really talk about what is in the DOL PBM disclosure rule. And lots of folks on this call might be either independently or in coordination with associations they work with, working to put their last finishing touches on their comment letters, because comment letters are actually due on this tomorrow, and that was subject to an extended date. So I think, folks have been looking at this rule and digesting it. So this rule, as Julia mentioned, published just a few days before the legislation, does not apply to governmental plans, does require, again, a lot of information for PBMs to be disclosing to their ERISA covered self-funded group health plans, and all related to compensation and fee disclosure. And it also does include, it has kind of a broad brush, including consultants providing advice, recommendations, or referrals. So again, in instances where there are none or not significant fee structures, it's not going to be that complicated, but obviously with the PBM aspect, this is a very complicated disclosure area. And we can go ahead to the next slide. So just taking a look at some of the fundamental aspects of the DOL PBM disclosure rules. So again, there's lots of overlap and complement, but there's lots of distinction between the regulation and the legislation. And so, for instance, you heard me talk about that semi-annual disclosure under the legislation, and then that summary document annually, right? And in the DOL PBM disclosure rule, we're looking at PBMs making disclosures when they initially are retained, and then at any time there's an extension or renewal of the services, and semi-annually thereafter. There's a lot of details we'll go through in a minute about what the DOL is thinking about in terms of what the content of those disclosures. There was clarity in the proposed rule that fiduciaries have the ability to ask for additional information. Again, a notice requirement. So thinking about there being a notice available, letting participants and beneficiaries know about their rights under this rule for them to get information. And then audit rights of the plan was another focus area on this. So sort of not making it a requirement to audit, but trying to really support and highlight the audit rights available to plan fiduciaries, that they would be able to do it on a at least once a year basis, that they would be able to not be limited. Lots of times right now you see agreements that really limit where an audit might be able to take place. There could be limits on things like that. Starts to look at expenses of how these audits might be paid for, right? And so, I think there's a lot of detail in this rule, and again, people are working on their comments, but I think one of the big things that has come up is when you think of a plan trying to navigate this, how can this now all be melded together in a way that kind of works in partnership and can create a uniform system? Because otherwise it's going to be very difficult if you're kind of meeting similar but two somewhat different constructs, right? So uniformity there is going to be really important. And we can go ahead to the next slide. So again, I won't read every item on the slide, but proposed disclosure of that information initially upon extension and renewal, things like description of service, direct compensation, manufacturer payments, spread compensation, copay clawbacks, price protection agreements, how formulary placement incentives affected how that formulary was designed, drug pricing methodology, a request that a PBM make a statement of a fiduciary status if they are holding themselves as a fiduciary. So lots unpacked in there. This rule is written in a really detailed way, and really the regulators were asking a lot of questions, specific questions about, specific terms. So I think it will be very interesting to not only see what group health plans provide as feedback in that comment process, but what are the other entities, such as the PBMs, going to say about what's workable or challenges they might face? Because I think we all know the challenges a PBM might face in some of these disclosures ultimately trickle down as a challenge to the plan, right? Because we're already thinking about what's going to have to be disclosed to that plan. What does the plan have to monitor and know they received in compliance with the law, and what's going to be workable, and where are we going to find challenges? So these are all things I think we're starting to think about. We can go ahead to the next slide. Again, good news being that this is a proposed rule, right? So it could become applicable. In the proposal, they were suggesting as soon as July of 2026. But I think we will see, I think one of the comments, another theme of comments will be what's really the timing of applicability of this rule, and how do we take this and read some of this together with now all the requirements under that parallel legislation, and how can we think about timing that might work for melding all of this together. So I think the departments are going to hear a lot about that in the comments they receive. So in terms of those semi-annual disclosure, again, not as many, but many of the things that we saw in the initial disclosures as well. And we can go ahead to the next slide. And here we'll just touch a little bit on some of the other pharmacy benefit updates we have. But before I jump into that, I do want to spend just like another minute on where we are with that PBM fee disclosure rule, and thinking about, some of the things that you'll see as you look at the legislation, and as, again, you or the associations you work with, or even your PBM are looking across the regulation and the legislation. There's things like terminology variations. There are, the timing questions. So there really is this question of what kind of alignment can ultimately the federal departments perhaps create. And I think the big question, kind of echoing back on that slide we saw earlier about monitoring and fiduciary duty, is that same structure of a prohibited transaction, so an exception if you meet the requirements of reasonableness, and really thinking about what is the expectation on the plan fiduciary in terms of how they're going to monitor this information, and what the departments will ultimately expect as how that is reflected back to them, right? And so I think that's something we're really watching and wanting to get more guidance from the federal departments about that, and really a workable framework for plans, so that this is something that can be done in a way that plans can know they've kind of met their obligation, right? And then moving ahead, as we think about that, we also know there's other pharmacy benefit initiatives, or other initiatives that are happening that are impacting pharmacy benefits. So one concept is that with the new administration, we really saw this idea of the most favored nation prescription drug pricing come into play. So then in December of this year, the administration proposed 2 Medicare pilot programs to reduce prices for brand name drugs and drugs administered at a provider's office. We can go ahead to the next slide. Basically, the way this program would work is looking at the drug pricing against what's being paid in other countries. We can go ahead to the next slide. And using those benchmarks to align the pricing. And so those 2 programs are the Globe and Guard programs. These programs would be coming online in 2026 and 2027 if they are finalized. We can go ahead to the next slide. These models were open for comment, so the departments did receive comments through February. So I think the question now becomes, what does become the real timing, and are these adopted? And they would be implemented randomly across different geographic areas, representing 25% of people who have Medicare Part D plan, or in a Medicare Part B plan. So each of those programs apply to, the one applies to Part D, the other to Part B, respectively. So that's an area that we are watching. And then if we go to the next slide, another area.
Let me pause you for one minute. I have a question for Eileen. I was wondering, Eileen, if you could share some of the broader impacts of these most favored nation drug policies across the industry.
Yeah, sure. Thanks for the question, Julia. So, at high level, what Elena mentioned, the MFN policies are really designed to lower drug prices by tying what the US pays to what other countries pay. So they're mainly aimed at Medicare, but they can definitely create ripple effects that employers end up feeling too. On the positive side, they put more pressure on drug manufacturers to keep prices in check. But there's also a lot of uncertainty, right? So that comes with that. Manufacturers might react by pulling back on rebates. They might pull back on discounts, tightening access, or even changing how quickly new drugs come to market. But the important thing to understand is that the MFN policies, right, don't automatically lead to quick savings. So it's important, right, that plans stay flexible, keep an eye on changes in pricing and access, and actively manage the PBM contracts. Thanks.
Gotcha.
Thanks, Eileen. And I know Eileen's going to have things to chime in about on this topic as well. So another thing that we kind of see happening in the marketplace is that Trump RX has been introduced, and we can go ahead to the next slide. And again, this was driven by, the initial executive order related to lowering drug prices. And then we saw this series of different deals that were entered into with different drug manufacturers targeted at specific drugs that would be offered generally a direct-to-consumer access point, a price access point, and at negotiated lower prices. So we saw this change, and it really is creating, a consideration about, well, what does that mean in terms of that there is this availability of this product at a certain price in the marketplace. We know that many, if not most, group health plan overall contracted negotiated PBM rates often already have pricing for many, if not all, of the drugs at the same, similar, or better prices. But it's not a one size fits all thing. So this is just, another consideration, and we're seeing that there are there's about 40 medications available, and there's either coupons or links to the manufacturer to get that direct to consumer pricing. Lots of them are medications that are older brands that have generics or generic alternatives now available. So individuals might not really be trying to access that version necessarily. And we can go ahead to the next slide. But using that, site may be a possibility in some circumstances. However, there are a lot of considerations because prices may be higher than copays. Again, cheaper alternative drugs or generics might be available. Drugs that do not pay rebates or price comparison to the plan prices, how to compare that can be difficult. So there's kind of all these considerations, and it won't necessarily be an alternative or a consideration for many group health plans, but it is kind of something that's generating a lot of questions. And I know one of the drugs that is part of the deals that were on there includes GLP-1s. So I think, Eileen, you might have some commentary on that.
Yeah, Eileen, we know that GLP-1s is an area where direct-to-consumer pricing is being made available through Trump RX and in some other by some other avenues as well. How might this be significant to group health plan sponsors?
Yeah, so I think what's really important about the direct-to-consumer, especially the GLP-1 pricing, is that it really gives employees a very clear alternative to going through, outside of their employer plan. So, it's no longer just about whether GLP-1s work, right? We know they do. The question now really is, how do you want to pay for them, and how much cost risk are you comfortable taking on? So under a traditional PBM model, right, employers usually end up with higher ongoing costs, right? But they're also keeping important guardrails in place. So things like prior authorization, clinical oversight, access to rebates, right, that help manage spend. The downside is that the cost can grow quickly as more people qualify for these types of drugs. Now, a DTC option, right, direct to consumer type of option plus an HRA approach, that offers a different type of option. So employers can put a fixed contribution toward a known cash price, which can make costs more predictable. And in some cases lower, especially for weight loss use. So the trade-off is really, giving up some of the traditional controls and rebates and shifting more responsibility to the employer. So the bottom line is that, there's really no one size fits all answer here. It really comes down to, what fits in your budget, how your workforce thinks about the benefits, and your comfort level with the long-term costs of uncertainty. You can go to the next slide. All right, so this is the Medicare Bridge and Balance Program. So you probably heard of this. CMS released the balance model, which outlines requirements for Medicare Part D plans to participate. So that includes coverage of GLP-1s with standard condition-based prior authorization. And participation is April 20th that you see there at a CMS contract level. So it's not by plan. There's also a Medicare Bridge program that'll run starting July, which serves as a short-term transition to the full balance model. So I do want to mention, we do have some EGWIT plans, looking at this now. Some have not made that decision yet as they're still evaluating. So that's still ongoing at this point. But anyway, plans will have to make a decision soon. Okay. Go to the next slide. Yeah, so in this whole section, I'm going to touch on the RX strategies in response to PBM reform. So if you look at this slide, after everything happening in Washington, right, it's clear regulation is stepping in, but it's also adding new layers of complexity. So most PBM contracts are now touched by regulation in some way, like the FTC, right, which means more disclosure, more oversight. There's that FTC settlement with Express Scripts, which is pushing away rebate-driven formularies and more towards net cost pricing and transparency, which really gives plan sponsors more ability to lower the members' costs. At high level, the PBMs are facing pressure from several directions at once. Contracts themselves have become more complex with ongoing concerns around definitions and incentives. And then on top of that, service and operational issues remain a real challenge. And then, just talking about transparency again. So even with the transparency rules, contracts still remain complex and the fine print still matters. And it's really easy for costs or risks to hide if you're not actively reviewing it. So the bottom line is that regulation, isn't a silver bullet, right? It's important to stay engaged and be proactive. Next slide, please. So we spent a lot of time talking about the rising costs and regulation, but to really understand, why PBM strategy matters, it helps to take a step back and really ask a basic question, how do PBMs actually make money? So at high level, there are a few core revenue streams, that you see here in the slide. One is transaction fees. That's a small per prescription charge. On their own, they may seem minor, but across millions of claims, they become really meaningful. Another is spread pricing, which is the difference between what the plan pays and what the pharmacy receives. So that can exist at retail, it can exist at mail or even specialty. And it really becomes especially important when the PBM owns their own pharmacy, right? So we know some PBMs own their own specialty pharmacy, their own retail, so it becomes important there. And then there are manufacturer payments, so rebates, data fees, and other financial arrangements that are tied to formulary placement. Much of this money sits outside the claim, which is why it can be hard for employers to fully see it. And finally, there are service fees for things like clinical programs, copay assistance, specialty services. So the key point is that, this is how PBMs have historically made money, but the model is really under pressure at the moment and will eventually change. So regulation, market shifts, are all challenging the spreads, the rebates, the incentives. So contracts that worked, even a few years ago may not hold up, going forward. So understanding this foundation is really critical to avoid, any future surprises. Next slide. All right, so tips to reduce waste and abuse. So once you understand, where the PBM revenue comes from, the next question naturally becomes, what can employers actually do to reduce waste and keep costs in check? So in practice, this comes down to a few very tangible steps. First, it's worth taking a fresh look at the PBM market. Many employers are still operating under contracts that were signed years ago, before drug pricing dynamics changed and as dramatically as they have. Second, tightening up contract language really matters. So definitions around pricing, rebates, guarantees, and exclusions can quietly drive cost over time. And small words can have very big financial consequences. One of the most powerful levers is also the drug level rebate disclosure. So when employers know exactly which drugs are generating rebates, they can better assess, whether the formulary decisions are truly based on lowest net cost, or is it something else? And finally, more sponsors are exploring shared risk models with PBMs. When incentives are aligned around controlling future price increases, results tend to improve. So for example, instead of paying a PBM purely off rebate volume, a plan sponsor might enter a shared risk model where the PBM is financially accountable for year-over-year drug trend. So if overall pharmacy spend grows faster than an agreed upon target, the PBM shares in that downside. So if trend stays below target, the PBM shares in that savings. And when both sides are aligned around limiting future price increase, not just maximizing rebates, you tend to see better formulary decisions around that. Next slide. So beyond contracts, a lot of cost control happens, inside the benefit itself. It really starts with utilization management. A well-designed prior authorization program helps ensure medications are being used by the right people for the right reasons at the right time. It's one of the most effective tools plan sponsors have to manage trend. Formulary strategy, that's another area. It's another critical area. So that means being intentional about steering to the lowest net cost option, not just the drug with the biggest rebate attached. And there's also ongoing need to actively manage fraud, waste, and abuse. Things like duplicate therapies, inappropriate prescribing, or pharmacy practices that drive unnecessary utilization. Those can add up quickly. And specialty drugs, they really deserve its own special focus. So when pharmacy and medical benefits work together, what we think of as integrated specialty management. So employers gain much better visibility and control over their high-cost therapies. So for example, for certain self-administered or clinician-administered drugs, routing coverage to the pharmacy instead of medical can really improve transparency and give plan sponsors more control, especially for the high-cost specialty medications. And none of these tools are new, right? But when done thoughtfully and kept up to date, it can really significantly slow trend while still supporting access and quality for your members. Next slide. So for PBM contracting, this is where plan sponsors often have more leverage than they realize. It really starts with clear contract definitions. Ambiguity, can get really expensive pretty quickly. So clear pricing terms, rebate treatment, fees, and guarantees are upfront. And, if you look at all that, there's fewer surprises that you face later. Next, performance guarantees, right? That should actually reflect what matters to you. That might be cost control, it might be service, quality, clinical outcomes. So it's not just metrics that are easy for the PBM to meet. It should really mean something for you guys. Reporting is another big piece. Employers need data that they can actually use, right? Financial, clinical, operational, not reports that just check a box without driving any action. And finally, having the ability to periodically perform a market check really matters. So the market keeps evolving, especially in the pharmacy space. And your contract should allow you to validate that your pricing and terms remain competitive. So strong PBM contracting, without a doubt, isn't about being adversarial, right? It's about clarity, alignment, and accountability. Next slide. Okay, so the last important lever I did want to mention is plan design. So how the benefit itself is structured and how it influences members' behavior. So member cost sharing, it does play an important role here. Designs that gently steer members toward lower cost options like percentage-based cost sharing with reasonable minimums, reasonable maximums, that can really influence behavior without creating barriers. For copay assistance, that's a pretty popular program. While these programs still help manage member affordability and specialty spend today, their future is uncertain, right? So using them thoughtfully while they're available can still make sense. And the big picture here is that good plan design, it isn't about shifting costs to the employees, right? It's about aligning incentives in order to support both affordability and adherence for members over time. I'll turn it back to Elena to talk about some fiduciary considerations.
Thanks, Eileen. So as I mentioned, there's we can go ahead to the next slide. There's these themes swirling, whether it's under the legislation or under the regulation and with specific amendments to 408B2, there's really this swirling topic of what will the fiduciary obligations be in this new space of elevated PBM transparency. And let's face it, lots of the outcomes of this rule in the long term can be positive. Eileen's talked a lot about where we are with the pharmacy trends, and plans will be empowered with more information to help them negotiate with their PBMs, and that can be good news, right? But at the same time, there's the counterbalance of that is it is a lot of information that's going to be available, and what are the obligations of those plan fiduciaries to do with that? And so I think then to kind of just take a step back and review what are ERISA fiduciary responsibilities. They include acting solely in the interest of participants and beneficiaries, with that exclusive purpose of providing benefits, making sure the duties are carried out prudently, following the plan document. And we know that happens even now, right? There's things in a plan document, and that's not how it's being administered, and that gets found out through those audit processes and plan reviews of those activities. Ensuring that reasonable expenses are being paid for the services that are being provided by the plan. And that's a big part of the energy around this rule, is giving plans that ability to kind of look under the hood and know more about what and how they've been being charged, and taking obviously some of the mystery away from that. So then it does come back around to, well, then what is going to be the obligation of that plan? What are they to do with this information? And how are they going to continue to work with their PBMs around that? And we talked about how in the legislation, there's kind of the innocent fiduciary standard. For instance, if a rebate's not passed through, you'd be saved if you kind of move forward and take corrective action. And in the regulation, we see this idea of, if your PBM is willing to be a fiduciary for you, they can say, we will be the fiduciary for you. They can put that in writing. Well, doesn't that seem like a great idea under the circumstance, right? So that might be something you want to ask for, that you want to try to negotiate. Will your PBM agree? That depends, right? But this is a time where you be considering those things. When you're considering negotiating in the contracts, we know there's a lot to shake out here, right? There's a lot of, there's going to be 18 months that the government has to issue regulations under the legislation. The DOL rule is a proposed rule. They're going to get comments. We'll see what they do. And we have those two events happening side by side. So will they be reconciled? So we know all that's going on, but nonetheless, we know that this PBM reform for sure is on the horizon and moving forward, right? So this is a time to negotiate into those contracts with your PBM. Are they going to support you with these compliance efforts going forward? How's that going to work? This is a time to begin to have those discussions. I think it's also a time to start to think about refreshing fiduciary training internally. If folks in the plan, are going to be involved directly, have they been kind of revisited with the requirements in a while, kind of really thinking about that, and then enabling that baseline training to kind of be a bridge to think about how are those obligations of a fiduciary going to line up against the expectations under these new requirements. And I will say, I think there will be comments. I've already seen comments filed with the government under the rule that are looking for things like information from the government about how plans would review, possible safe harbors for plan sponsors if they take certain steps to make sure they have collected information. Can there be sort of streamlined ways that they can provide oversight of this effort, right? So I think the departments are going to have to digest all that too, and we'll be waiting to see what they say more. And I think with that, we can go ahead to the next slide.
So next steps. Elena and Eileen, I was wondering if you could wrap us up by providing some kind of concrete next steps that plan sponsors can take in navigating this evolution in the pharmacy benefits space. I know fiduciary training, for example, for health plan fiduciaries isn't necessarily something that most plans are accustomed to doing at this point, but I know there are a bunch of other next steps as well.
Yeah, I can respond first if that's okay. Yeah, so I would say, first, get grounded in the basics, right? Like make sure you understand, how your pharmacy program is priced, where rebates and fees are actually flowing, what your PBM is truly being paid. That clarity matters more than ever. Second, use the tools you already have, right? Review your contracts, exercise your audit rights, hold vendors accountable for doing what they said they would do. Third is also building flexibility right into your strategy. New drug pricing models and coverage options keep emerging. I've seen a couple of new models that came out, with some of the bigger PBMs. So it's moving forward. It's important not to lock yourself into a one size fits all approach. You need to be ready to evaluate alternatives as the market changes.
Thanks, Eileen. And I would just, follow that up with if you've been reviewing the PBM disclosure rule and working on your comments, get them filed, right? And then we know there's really a lot more guidance to come. So kind of take a deep breath, keep an eye out as the guidance comes, and you'll be working through it kind of in stages and hoping that maybe that comment is heard loud and clear, that the industry needs time to kind of stand this up and work together to help the compliance aspects of this move forward. And to Julia's point, I agree, fiduciary training might not be something plans are thinking about on the daily, but it is really a time to really step back and look at what are the requirements, what's going to be happening, what's going to be put before our plan, and what do we think is going to be an oversight approach to these PBM disclosures that we as a plan feel comfortable with, and that we'll feel will stand up to support that we've kind of met our obligations. So a lot of it will still be unfolding in guidance as well, but I think those are some starting points.
So we have just a couple of minutes for questions, and the first is for Eileen. Pharmacy costs are eating up nearly 30% of health budgets, right? So why does this moment feel different from past affordability challenges?
Yeah, that's a great question, Julia. I think it feels different because pharmacy costs, it used to be something you could kind of wait out, and that's really just not true anymore. In the past, when drug costs went up, there was usually sort of like a reset built into that. A new brand drug would come out, spending would rise for a bit, and then generics or competition would show up and push prices back down. So that happened with a lot of everyday drugs like blood pressure medications, cholesterol drugs. And what's happening now looks very different. The biggest drivers today are things like biologics, autoimmune diseases, GLP-1s for diabetes, GLP-1s for obesity, and long-term cancer and specialty treatments. So these drugs are often taken for years, sometimes for life, and they're not, there aren't easy generic replacements. And they're being used by much larger groups of people. And on top of that, pharmacy pricing really hasn't gotten a lot harder to follow. So what plans actually pay isn't just about the drug prices anymore, right? It depends on the rebates, where the drug is filled, the whole mix of fees, incentives, and when you pull all that together, pharmacy spending, doesn't naturally level off anymore. It keeps building year after year. And that's why employers are feeling the pressure so closely, and why pharmacy costs, are now directly competing, with wages, benefits, and overall affordability.
And one last question for Elena, as I see we're wrapping up here. What would you see as the biggest concerns for plan sponsors as we all watch this evolving area and think about plan sponsor challenges?
I always look really far down the road, right? To after this is all settled and enforcement comes, and my concern is, will there have been a clear path made for plans in terms of what were their duty to monitor? How do they fulfill those obligations? How do they reflect it in a way that's kind of clear and concise and seamless? And later when you're audited by a federal department, you're in a good position because you had clear guidance about what you need to do and how. So I think that's on the horizon, and working towards that is, I know, what our plans will all do very diligently. I will mention we felt like there was so much information to put in this webinar, and we had almost wanted to do like a one-on-one 101 about things like, what is spread pricing, and how do these things come up in your contracts, and there really wasn't time given all the updates we have, but and we also know that there's over 100 comments to the PBM rule already filed and more to be entered. So we kind of wondered if subsequent update in the nearer term would be useful to folks, where we could kind of bridge some of the fundamentals with kind of how things continue to unfold. So I think there was a polling question that folks intended to enter to get feedback on if that feels useful to the audience, or how that would be received. So.
All right, well, I see we're 1 minute past the hour. Thank you very much to everyone for your attention. And as I said, we will be circulating a recording of this webinar. Have a great day, everybody.